Marianne, ladies and gentlemen, good morning. Now, this picture was taken in 1964 when the Beatles performed for the first time in the United States. This was on the Ed Sullivan Show. You know, the Ed Sullivan Show was a very popular weekly show on CBC. But this night was very different. More people than ever were watching. And people were shouting, screaming, and crying. Now, here's a question for you. Who came on stage after the Beatles that night? Raise your hand if you know. Nobody. Well, this is what I was afraid of. You know, this is my destiny here this morning. Performing after the Beatles. It's a very difficult task, you know. Did you know that Aseem Malhotra has been called the rock star of cardiovascular prevention? And you know why? You heard him this morning. So I was thinking that with him being the rock star, and if I do well here this morning, that you might want to call me something like that. But of course, I'm a bit older than he is, so my idea was that you could call me the Willie Nelson of dietary fats. And what an extraordinary guy he is. 83 years old and still on the road. The impact of healthy lifestyle is amazing. Now, this is Landspitali, our university hospital. This picture was taken 90 years ago. Now, what do you think was happening behind these walls 90 years ago? I can tell you it was very different from today. 90 years ago, people were mostly dying from infectious diseases. Diseases like pneumonia, tuberculosis, gastroenteritis. Today, it's completely different. Today, it's all about non-communicable disease, or NCD. I think I'll have to put on my glasses. I'm getting older. Now, in fact, NCDs kill approximately 38 million people each year. 16 million of those deaths occur before the age of 70. So we are really talking about young people here. Cardiovascular disease is the most common cause of death, followed by cancers, respiratory diseases, and diabetes. And it's all about lifestyle. Tobacco use, physical inactivity, the harmful use of alcohol, and unhealthy diets all increase the risk of dying from an NCD. And this is what Footloose is about. It's about improving our health by lifestyle. Even the pharmaceutical industry knows that it is all about lifestyle. Now, dear people, take a look at the person sitting next to you, just for a couple of seconds. It really hurts me to tell you that one of you will probably die from cardiovascular disease. That's the scope of the problem. So listen carefully. Why would we not want to eat fats? Isn't it quite obvious? Because fats clog our arteries, and fats make us fat. And that's why we invented low-fat products, right? Almost all of the fat we eat is in the form of triglycerides. Only a small fraction is phospholipids and sterols like cholesterol. So a molecule of triglyceride is composed of 3 fatty acids attached to a molecule of glycerol. And these fatty acids can be saturated like this one, which has no double bonds. They can be monounsaturated like this one, which has 1 double bond. And they can be polyunsaturated like this one, which has more than 1 double bonds. Now, the famous US physiologist Ancel Keys, among others, was responsible for formulating the so-called diet heart hypothesis, which holds that eating cholesterol and saturated fat raises blood cholesterol, and that this may lead to increased risk of heart disease. So the message that got out was that a healthy diet is a low-fat diet. And as we all know, this message was received by the food industry, setting the stage for the popularity of low-fat products. So low-fat foods were supposed to improve our health, to lower cholesterol, and to reduce the risk of atherosclerosis, and of course to reduce the risk of obesity. The famous American Heart Association had already made up its mind in the 1950s. And this is taken from a paper from one of their committees, which was written 60 years ago. And I'll read it for you. Most persons in the US who are overweight will find it profitable to reduce their calorie intake. Reducing the amount of fat is one way to do this. In addition to the possibility that atherosclerosis will be prevented, obesity will certainly be controlled. A reduction in blood cholesterol by dietary means, which also emphasizes weight control, may lessen the development or extension of atherosclerosis and hence the risk of heart attacks and strokes. But they still found it appropriate in the same paper to write, "It must be emphasized that there is yet no proof that heart attacks or strokes will be prevented by such measures." So you have to wonder, if the evidence wasn't there, why go out with a recommendation? This is an Icelandic paper showing an 80% decline in the mortality from coronary artery disease in a 25-year period between 1981 and 2006. The authors used a statistical model, so the so-called impact model, to analyze the reasons for this huge decline in mortality. And what they found was that 75% of the decline was caused by reduction in major cardiovascular risk factors in the population. And the three factors that were pinpointed were lower blood cholesterol, better control of hypertension, and less smoking. But in the same study, they also found that the increasing prevalence of obesity and type 2 diabetes was shifting the curve in the opposite direction. So it was concluded from this study and other data that was available that the lowering of blood cholesterol had played an important role in lowering mortality from coronary heart disease in Iceland. Less smoking and better control of hypertension also played a big part. Lowering of blood cholesterol and blood pressure was mostly due to less intake of salt and saturated fats, as well as hydrogenated fats or trans fats. And this was a result of public health campaigns during the 80s and 90s. But if public health authorities are taking the credit for the lowering in mortality from coronary heart disease, they will also have to shoulder the blame for the obesity epidemic because it happened on the same watch. Now, so we went from slightly fat to very fat, and it happened very fast. These figures show how the prevalence of obesity increased among Icelandic men and women during a 17-year-long period between 1990 and 2007. And actually, this was exactly the same period that fat intake declined. But we will also have to keep in mind that at the same time, the intake of added sugars, sugary beverages, and refined carbohydrates increased. And even more importantly, the intake of energy-dense, highly processed fast foods skyrocketed. It's important to keep this in mind. Now, let's talk a little bit about coronary artery disease. This is a disease that I have been dealing with almost every day of my professional life for the last 25 years or so. And you see the typical coronary, sorry about that. You see the coronary plaque here. Now, what kills people with coronary heart disease is not the narrowing itself, it's the plaque rupture which causes thrombosis or blood clotting. But look at the yellow thing here. The yellow stuff we see in this coronary plaque, what is it? It's fat, isn't it? It's the fat we eat that gets stuck in our arteries, right? No. That's rubbish. But that's what we've learned, and we've looked at it like this for a long time. But in fact, a coronary plaque is much more complicated than this. And the root cause of atherosclerosis is the retention of atherogenic lipoproteins within the arterial wall and the subsequent inflammatory response. I'll come to that later. Now, was Ansel Keys right? Do dietary fats cause coronary artery disease? In fact, randomized studies addressing this question are very few. Metabolic studies have primarily used surrogate endpoints such as blood lipids and other biomarkers. So our knowledge and recommendations have to a large extent been based on observational data, which is really not able to prove causality. In recent years, several meta-analyses have looked at the relationship between saturated fat intake and coronary artery disease. And these meta-analyses basically all show the same result. Here's an example. This one was published in 2000. This one was published 2 years ago, basically showing saturated fat to be harmless, long-chain omega-3s to be protective, and trans fats to be harmful. This is the biggest randomized trial addressing the question whether a low-fat intervention lowers the risk of cardiovascular disease. The Women's Health Initiative randomized almost 20,000 women to a low-fat diet or a conventional diet. And LDL cholesterol was significantly lowered in the low-fat diet. However, after 8 years of follow-up, there was no difference between the two groups in all major cardiovascular endpoints. The Predimed study showed a 30% reduction in cardiovascular endpoints on a Mediterranean diet compared to a control diet, which basically was a low-fat diet. So what we can say is that the low-fat approach is not really supported by any data from randomized clinical trials. Now let me take you back to the era when the first dietary guidelines were being introduced. The 1980 US dietary guidelines shaped the diets of hundreds of million people, also outside the United States. Doctors based their advice on them. Food companies made products to comply with them. And in 1983, the UK government issued advice that closely followed the American example. So what happened was that steak and sausages were replaced with pasta and rice. Butter was replaced with margarine or vegetable oils. Eggs were replaced with muesli. And milk was replaced with low-fat milk or orange juice. But the question is, was there enough scientific evidence for these recommendations? Investigators from the UK published this paper last year, where what they did was that they performed a meta-analysis of all randomized trials that were available at the time of the first guidelines, addressing the question whether a low-fat intervention would be beneficial. And their conclusions were quite sobering. In fact, government dietary fat recommendations were untested in any trial before being introduced. Dietary recommendations were introduced for 220 million US and 56 million UK citizens by 1983 in the absence of supporting evidence from randomized clinical trials. The present review concludes that dietary advice was not merely needs review. It should not have been introduced. These are the words of the authors of this paper. Now to another question. Is dietary fat a major determinant of body fat? In other words, do dietary fats promote obesity? As we heard here this morning, excess body fat is the largest nutritionally related problem around the world. Excess adiposity accounts for more than 40% of coronary heart disease cases, many cancers, most cases of adult onset diabetes, and a large proportion of disabling osteoarthritis. A reduction in obesity has often been a primary justification for reducing the percentage of calories from fat. Ecological studies have often been used to demonstrate a correlation between fat intake and obesity. And here's one such study showing a clear correlation, as you can see. But if you look closer, you can see that the low fat intake countries are poorer developing nations that cannot really be compared to richer Western nations. So here's a very good example of how we can be misled or fooled by observational data. So it would be much more appropriate to compare nations that are more similar to each other. And this is a study looking at the same question in European countries. And you can see that this study actually found an inverse correlation between fat intake and body mass index among European women. That is, more fat, less obesity, less fat, more obesity. Adipose tissue is a very important organ. The main role of adipose cells or fat cells is to store energy in the form of fat. Our ancestors suffered from periods of undernutrition. And if not for fat tissue, which was a storage area for fat, we would have perished. So fat tissue saved us from periods of famine and starvation. Modern man, on the other hand, suffers from periods of overnutrition. So the very same tissue that saved us as early men has now become a part of the problem. But having body fat is a normal thing. If there was no body fat, all girls would look like boys. And Marilyn Monroe would never have become famous for her looks. Most of us know that women in general have, in relative terms, have more body fat than men. But that is mostly because of subcutaneous fat. Subcutaneous fat is the fat that sits under our skin, sometimes called big butt fat in the US, if I'm correct. And actually, subcutaneous fat may indeed be quite good for you. There is evidence suggesting that the size of the subcutaneous fat depot correlates with longevity. So wherein lies the problem then? In order to understand that, we have to understand that, like any other organ, fat tissue can become sick. And there is a huge difference between healthy fat and sick fat. And it's usually the belly fat or the visceral fat that becomes sick. But fat tissue is not only a storage room. In fact, fat tissue is an important endocrine organ. For example, fat cells produce a substance that is called adiponectin. And adiponectin seems to be protective. It's the good guy. However, when the fat cells become sick, they start to produce other substances like TNF-alpha, interleukin-6. These are cytokines, sometimes called adipokines. And they actually promote the inflammation. And at the same time, adiponectin levels drop because sick fat produces much less adiponectin than healthy fat. So when we collect belly fat, our fat cells become sick and we risk developing the metabolic syndrome. And insulin resistance appears to play a key role, as we've already heard this morning. In order to try to overcome this, the pancreas starts to produce more insulin. So hyperinsulinemia, or high blood levels of insulin, are characteristic of insulin resistance and the metabolic syndrome. And insulin is the fat storage hormone. Insulin is really the key that unlocks the fat cell and allows energy to enter and be stored as fat. Insulin makes fat. The more insulin, the more fat. Now, with insulin resistance, we also have all these other problems here. We have inflammation, endothelial dysfunction, hypertension, type 2 diabetes, and we definitely have increased risk of atherosclerosis and coronary artery disease. So the metabolic syndrome is the new risk factor for coronary artery disease. The metabolic syndrome is a constellation of factors, including visceral obesity, low HDL cholesterol, high triglycerides, hypertension, and glucose intolerance. And if we have the metabolic syndrome, we are at almost a 6-fold increased risk of dying from cardiovascular disease compared to those who don't have the metabolic syndrome. Here's an interesting study that compared low-fat and low-carb diets, the effect of those two diets on weight loss in women with and without insulin resistance. And you can see among those women who were insulin sensitive, there was no real difference between the low-carb and low-fat diets. However, among the women who were insulin resistant, the low-carb diet was much more effective. So a few conclusions about the relationship between fat intake and obesity. Scientific evidence does not support the conclusion that dietary fats promote obesity, visceral fat accumulation, or the metabolic syndrome. In fact, studies on carbohydrate restriction suggest that increased fat intake may reduce body weight and visceral obesity. So to blame dietary fat or even all calories for obesity is an oversimplification and probably incorrect. And the last one is something we heard from Gary this morning. A food's long-term effect on body mass is modified by its complex effects on satiety, glucose insulin responses, liver fat synthesis, adipocyte function, brain craving, the microbiome, and even metabolic expenditure. Now, let's talk a little bit about cholesterol, a hugely important substance. But we don't have to eat it. Our liver produces it. And if we don't eat cholesterol, our liver produces more. And if we eat cholesterol, our liver produces less. But if cholesterol is such an important substance, why did we become so afraid of it? And there are several reasons, actually. One is that cholesterol is usually found within atherosclerotic plaques. Another reason is that some observational studies seem to show a correlation between blood cholesterol and the risk of heart disease. And the third might be that there is a disorder called familial hypercholesterolemia, which is characterized by high blood levels of LDL cholesterol and increased risk of coronary artery disease. Now, in fact, there are several studies within the field of cardiology and lipidology that suggest that the lower the cholesterol, the better. So we, cardiologists, have been trying to lower it for years. That has actually been our mission. And we can do it either by diet or by drugs. And in fact, cholesterol-lowering drugs have become the most prescribed drugs of our generation. Now, what about good and bad cholesterol then? Well, what I can tell you is that there is no good and bad cholesterol. There is only good cholesterol, and it's just a part of life. But there is lipoproteins. Cholesterol is not soluble in water. So in order to be transported in the circulation, it has to be carried by proteins called lipoproteins. And the lipoproteins are classified according to their chemical properties, mostly based on their density. And you can see all these different lipoproteins here. We have VLDL, IDL, LDL, and HDL. And all these lipoproteins carry cholesterol, but they also carry triglycerides. VLDL, for example, is the lipoprotein that carries most of the triglycerides. Some of these lipoproteins have a tendency to penetrate the vascular wall, which may actually be the initial process in the initial step in atherosclerosis. But in fact, only lipoproteins that contain apolipoprotein B are atherogenic. HDL, for example, does not contain apolipoprotein B, so therefore it doesn't penetrate the vascular wall. And we know that HDL cholesterol correlates inversely with risk. Now, here you can see the LDL particle. This is the most common atherogenic particle. And this is the thing we've always been afraid of. You can see, sorry about that. You can see that ApoB is the main lipoprotein. And the yellow and red stuff here is cholesterol and phospholipids. Now, the cholesterol within the LDL particle is the LDL cholesterol. And if we collect all the cholesterol within all the LDL particles, we have LDL cholesterol. Now, let's briefly look at what happens in atherosclerosis, because it's so important and there's so much misunderstanding going on. Here you can see the atherogenic lipoproteins. And here you can see how they penetrate the vascular wall. And they somehow get stuck there. They are retained. And when the lipoproteins are retained within the vascular wall, they risk getting modified. It's a chemical modification, mostly oxidation. And what happens next is that white blood cells, called monocytes, sense there is something wrong. So like sharks sensing blood, they enter the vascular wall where they become macrophages and they engulf the enemy, the modified lipoproteins. And then something very strange happens. The macrophages don't leave, which they should. They stay. And they contribute to all the aspects of the plaque, the initiation of the plaque, the progression of the plaque, and the plaque rupture, which is the most dangerous thing, because with plaque rupture, you run the risk of thrombosis and blood clotting, which may completely block the artery, which happens when we have an acute heart attack. So it is the lipoproteins that seem to initiate atherosclerosis, not really the cholesterol. Of course, there is cholesterol within the particles. And it appears that it is the number of particles that matters most when it comes to risk. We are used to measuring cholesterol itself and not the particle number. So, for example, these two patients have the same number for LDL cholesterol. However, the one on the right has much more particles than the one on the left. He has a higher number of particles, and he also has smaller particles. And the one on the right is at much higher risk than the one on the left, because he has more apolipoprotein B containing particles. And this one on the right is probably a patient with the metabolic syndrome. Now, what happens to our blood lipids when we eat fats. In fact, this is a very complex issue. I will not be able to cover it. But what generally happens when we eat saturated fat is that total cholesterol, LDL cholesterol, and HDL cholesterol all go up. So as LDL cholesterol and HDL cholesterol both go up, the ratio between those two doesn't necessarily change that much. What also happens when we eat more fats or saturated fats is that triglycerides go down. So the ratio between triglycerides and HDL cholesterol drops. And this may actually be very important because this ratio correlates with insulin resistance, particle number, particle size, and with the risk of developing coronary heart disease. So this ratio can actually be used by us doctors because in Europe we usually not measure LDL particle number, but we can use this particular ratio as an indicator of insulin resistance and risk. And this can be very practical in patients with a metabolic syndrome. Now, what about omega-3 fatty acids? Now, we know that these fatty acids may have several cardiovascular benefits. And there are a number of those. Omega-3 seem to lower triglycerides, they may reduce inflammation, they may improve insulin sensitivity, they may improve endothelial function. And this is the reason why we recommend eating fish at least twice a week. But if you have cardiovascular disease, you might even want to eat fish more often. Another question that is very frequently being asked by the medical community and often by my colleagues is whether the popularity of low-carb, high-fat diets will lead to a new epidemic of coronary heart disease. And why are we afraid that this could be the case? That's mostly because of the effect of those diets on LDL cholesterol. But if we look at the data, we can clearly see that trans fats are the only type of fat that seems to impose more risk for coronary heart disease than carbohydrates. There is no evidence that replacing other types of fats with carbohydrates is beneficial. So if trans fats are avoided, there is no reason to believe that the popularity of low-carb, high-fat diets will trigger a new epidemic of heart disease. This is data from Sweden showing how the intake of butter has increased in the last 10 years. You see the yellow curve. This is butter consumption, and you can see that it has almost doubled in 10 years. But still, the incidence of coronary heart disease continues to decline. Now, let me summarize. Recommendations to reduce dietary fats and saturated fats were not based on reliable scientific evidence. Apart from trans fats, dietary fats have not been shown to increase the risk of cardiovascular disease. Evidence does not suggest that dietary fats promote obesity. In people with a metabolic syndrome, increasing fat intake and restricting carbohydrates may promote weight loss and improve several metabolic parameters. And the last one is for my colleagues. If high LDL cholesterol is considered a problem, restricting the intake of saturated fatty acids may be recommended. But remember, we don't eat macronutrients. We eat food. So where do we find the good fats? It's not here. This is the thing we're going to leave behind us after Footloose. So it's the natural fats. The coconut, the avocado, the salmon, the butter, grass-fed meat, olive oil. And does anybody really believe that processed low-fat products are a better choice? I really don't. Now here's a picture that was taken 2 months ago in Reykjavik. And it clearly shows the impact of the forthcoming Footloose Convention. We will stop at nothing to improve our health. Thank you very much for your attention.